Hi, everybody. Welcome to our inaugural Academy of Osseointegration Hot Seat. This is number one of a series that we'll have. Our mentor in this effort is Dr. Joe Kahn on the social media committee as the head, and Lorenzo Tabelli. We're pleased to have Dr. Hom-Lay Wang as our initial hot seat participant. My co-host tonight is Dr. Alex Lin from the University of San Francisco. Hey, Alex, how you doing? So, just a little intro for Dr. Wang. He's currently president of the Academy of Osseointegration. He's Perio Program Director at University of Michigan. He's won several national and international awards in our field, has published more than 800 articles in implant dentistry. We're very lucky to have you tonight. First question, Hom-Lay, please share on a personal note your road from Michigan to presently AO president and what you would consider as your major life as well as professional accomplishments. It's all yours, Hom-Lay.
Thanks, Bob. Good evening, everyone, and good morning for some part of the world. And certainly, I think, welcome all of you to the first AO Hot Seat. You know, I'm a full-time faculty at the University of Michigan, and one of the very unique opportunity is I was asked to serve the committee, which is the website education committee in the AO back in 2005, and which I graciously agreed at the time. And probably not long ago, about 2 years, I was asked to chair the committee, and which is kind of volunteer, and I do a lot of work and develop a lot of things which I think lay down some foundation for the AO. And later on, I was working on the several committee service and slowly move up my ladders and eventually become a board of directors. What is unique for me during this transition is, you know, I'm a faculty, I teach at the university and I deal with students all the time. But when you move up to the ladder, to the kind of a organization, you deal with a different personality, you deal with different issues, more than the student side, which, you know, they are probably more simple and straightforward, and you can always try to help them. But in a corporate form, it's a little bit different. So with that in mind, I actually observe and learn and slowly move up the ladder to become a president. And I set a couple agenda. I think one of the major agenda is every one of you see it's AO and EO alliance, which I always believe people has to work together and collaborate will make it better for not only for the organization, but also for the world in general. So I think that's one of my dream. And I think I can tell many of you today, probably a dream come true, which we can actually work together, not compete with each other. And that's what I'm here for. And I think I learned through many of the different tasks, and certainly there's a hiccup and there's a disappointment, but certainly they all come with a lot of joy moment, which I'm enjoy every day become AO president, because I can make this society better, this organization better, and make everybody happy.
Thank you, Hom-Lay. Please show the case to start the case. And Hom-Lay has never seen this case, so he'll be quizzed on that, and then Alex will be presenting.
Thank you, Dr. Wang, for your very cheerful insight about your career path. So today we prepare a case for you. So this patient is a 65 years old non-smoking female. So this patient is categorized as ASA2, which means that the patient has a mild systemic disease, but not threatening to her life. So the patient came in today for number 29, the number 30, which is the lower right second premolar and the first molar dental implant issue. So from the photos right here, you could see the patient was suffering from the recurrent peri-implant abscess at number 29 distal. These two implants were placed 5 years ago, and these two implants were micro-textured HA-coated surface implant. The crowns for these two implants were cement-retained crowns. So number 29 was a 3.7 millimeter diameter dental implant, and the number 30 was a 4.7 millimeter diameter implant. And you could appreciate the soft tissue texture and the contour right here on the right side of the screen. And in the meantime, if you look at the left side of the screen, you could appreciate some bone loss at the distal of number 29 implant. So we can go to the next slide, please. So here we also had the history of these implants. These implants were actually placed 5 years ago, but after 6 months of the implant placement, this X-ray right here was taken 6 months after the implant placement. You could see that on the left-hand side, 29, the 30 implant, there was no apparent bone loss around this implant. And we also had the period chart right here for you. So the right-hand side of the screen, you could see the period chart of number 29, number 30 implants. The probing depth, they were all within 3 millimeters, nothing really above 4 millimeters right here. And really minimal BOP around these two implants. There could be a little bit plaque, but everything else seems to be normal. Next slide, please. And now we have another 5-year follow-up slide for you. So as you could see here, 29 number 30 implant, we started to see some peri-implant bone loss on the 29 distal. And if you take a look at the chart, number 29, number 30 implants, we start to see the increasing probing depth and bleeding on probing around the number 29, the number 30 implants. So with all the information given right here, Dr. Wang, please share with us your diagnosis and your prognosis for both implants, number 29, number 30. And in the meantime, what do you think the patient got to where she is today, given the 5-year history of these two implants?
Okay, I think basically what you show this 5 years follow-up, it's looking into the X-ray and looking in the beginning. In the beginning, we know when implant put it in the solid bone, they shouldn't have a bone loss. And this is a microtexturous HA-coated implant. And I assume that it probably has a micro thread. Am I correct? This is the Zimmer T implants, I assume. But anyway, yeah. I can see it. But you can see that because this does not hold the bone. So the bone is going to remodel down to the first thread. That's number one things you have to understand. So if you're looking in the both implant, the X-ray is showing the bone level is in the first thread area. If you see the radiolucency all the way. So that's one reason you see that. Now, the second issue is the peri-implantitis certainly is a bacterial infection. It's a microbial as a primary focus, but there are many contributing factors. As you show that this number 30 is over contour. As well over contour, there's no way patient can get access to clean. And you probably did a free gingiva graft. I can see the bend of a free gingiva graft on the gingiva there. It's trying to help patient to maintain. Nonetheless, if you're looking into one of the things which is very important for me, I always joke around, and I have publish a paper with my students, talk about peri-implant prostatitis. Even though I understand PROS does not cause peri-implantitis, but PROS can trigger this a difficulty for patient to maintain a clean, and also it violates the, we call it supracrestal tissue attachment, or adhesion. In the implant, we call it adhesion. In the natural tooth, we call attachment, because we don't have a true attachment. So in this sense, your margin was way low in the number 29 implant. So you're going to see the bone is going to remodel down 3 millimeter. And that will give you the microtexture exposed to the oral cavity. And it can be difficult to maintain. So you're going to see the bone loss there. And in the mesial side, which they go down to the first thread and stop there. But this is in between. The patient may have a food trap and may be difficult to clean. And so the disease go down and you see the exudative pus coming out. But that's the one contributing factor I will look at is violate the supracrestal tissue adhesion and so-called the old term biological width in the implant. Now, in the number 30, even though you have a bone level down to the first thread, appears that normal, there's no further bone loss. So I will change the crown contour to the less than 30 degrees, and make it easy for the patient to clean. And then probably make some of the, either you can do in this case, if you look at the prognosis, you probably needs to replace some of the prosthesis, and then you can treat it and maintain the bone level in the 29 to the level of the bone, like number 30. So you can try the GBR because you already did the soft tissue graft, and you can open the area for patient can clean. And I think that prognosis will be a good one. Therapeutic prognosis can be a good one.
Mike, can you just be a little bit more specific regarding 29? So 30 looks like we have a pretty good prognosis, maybe a GBR procedure. Just review again number 29, what you would recommend.
Number 29, I will remove the crown if I want to treat it. I believe in a submerged GBR approach, because if you let the implant crown on it, that's called non-submerged. And trying to grow bone, it's very difficult. So I published several papers on submerged. So I will take the implant crown off and put a heating cap, let the soft tissue heal. Then I will go in and do my implant detoxification at the time of the surgery on the 29th. So I may need to do a implantoplasty to remove that the rough surface exposed, at least 3 millimeter. That's the number one things I do. And then I will use laser. I like using urban yak laser detoxify. Then I use the airflow to polish the area. And sometimes people debate using the tetracycline chemical treatment. I sometimes like it. I still believe a Raleigh method, old concept, and that may help. And then I will do a GBR with the dense PTFE membrane, fix it, and then primary closure with the tension release flap, and let it heal for about 6 to 8 months. And the bone graft I like to use is a mixture of autogenous, which I get access to the distal area, which is tuberosity area, not the retromolar area, so I can grab autogenous bone. I want a 1-to-1. If I use in the allograft at 1-to-1 ratio. If I use in the xenograft, I like to have a 70% of the autogenous and 30% of the xenograft. Then I will use in the PTFE with the perforated and fix it with a tension release, get the primary closure, like my past principle.
Couple questions, Hom-Lay. Any biologics in this case you would recommend?
You certainly can use a biologic as an agent. To me, some people mix with the PDGF. Some people mix with the PRF. I probably use the PRF in this case because I can make a sticky bone, which is much easier for me to manage the area. And also I will put the PRF outside of my dense PTFE membrane to promote the wound closure.
Alex, a couple questions from you.
Sure. So, Dr. Wang, you still have not mentioned about the diagnosis of these two implants. Do you think they have the same diagnosis?
The first one, 29, is periimplantitis. The 30 is not. It's probably periimplant mucositis. That's what I will look at because that's biological bone remodeling. From this side, I didn't see the mid-facial mid-lingua, so I don't know. Okay. But X-ray shows that it's a periimplant mucositis.
Okay.
On the clinical picture you show me.
Okay, sounds good. So you also mentioned about you will prefer to remove the crowns before you attempt your GBR procedure. So I'm wondering, since these crowns are cement retained crowns, removing the crown pretty much mean that the patient needs to get the new crowns down the road in the future. How would you communicate with your restorative dentist to convince them getting the crowns off?
So that's a very good question. And there are a couple of ways to remove the crown. One is the destroy, the patient has to pay for it. But because this is an over contour, and this actually make it difficult for patient to clean, and they got the periimplantitis on 29. So I'm going to communicate with my referral doctor saying, in order to have a longevity and long-term stability, and we can try to use the laser to discementation if we can do it. Some people using laser to discement it, so you don't need to destroy the crown. So which we have the case report written up, but we didn't submit it yet. But that's one thing we can try to do it. If we can do it, that's wonderful. Then you can you have to reshape the crown eventually. You have to do it and you have to create we call the supracrestal tissue adhesion, that zone. And then you can create a space patient can get access to clean and create some space for the patient. So that's the way I will communicate. I know it's difficult, it's involves the money, but you can say we'll try to remove it without ask a patient pay extra, but the crown will have to change anyway in number 30 and number 29 too. So most likely you probably need to cut it.
2 questions, Hom-Lay. Cementation issue. These are both cemented also. And if we had a cement, what cement would you recommend? Would you say possibly cement may be contributory on either one? And also the controversy of implantoplasty. Is that a concern of yours?
Yeah, the cement possible creates the Tom Wilson shows 81%. That's high percentage. But to me, most people today using the screw retain a lot. Yeah. And yes, can be a residual cement or remnants. And usually the article by Girk, he shows that very easily. If you place the margin below the bone level down to about 1.5 millimeter, then the cement is difficult to clean. But looking in this margin, I don't think it's below the bone level by 1.5 millimeter. I think it should be able to clean it. But again, it may be a residual cement and buccolingual side, but X-ray does not show on mesial distal. So
yeah, the concern though is the resin cements. As you know, we can't see up to about 2 millimeters. Mm-hmm. So I think the dangerousness of using a resin cement needs to be noted. That we try to go always, if we can, screw retain, because in this case, as mentioned, we were screw retain, we could easily remove these and do the GBR procedure, and then out of the mouth, do whatever contouring we possibly can do. So that's, I think, a big takeaway to make this case easier to treat down the road. What about the implantoplasty? Is that a concern at all with the particles in the soft tissues?
I think a titanium particle triggered a foreign body reaction has become a debate issue. The research does not showing one way or the other, and we debate it. So I think more evidence is needed. And yeah. I personally, I do a lot of implantoplasty. I do not see a lot of foreign body reaction. And yes. So again, that's something remains to be determined. And yes. I would like to do, in this case, I will do a little bit of implantoplasty. I think that's the best way to detoxify the implant surface. Yeah. Besides another way to deal with it. So
while we have this case up and we're good with time, so your thoughts, if number 29 was hopeless, for example, say there was significantly more bone loss, 30's got mucositis, what would be your possible treatment plans to share with the audience?
If a 29 is mobile, and then we can remove it, and we then do GBR with the we call the implant socket augmentation and GBR, and then place the new implant. And then I think this is a little bit too close and difficult to put a breach. Originally, you probably can do a 2 implant from back and then end up with a breach. That can be also a potential to resolve these issues, because that crown has become so big and you have to occupy the space. So maybe breach, it's another consideration with a 2 implant with the same size. That can be.
What about connecting it with the tooth, number 28, as a possibility? If this is a,
okay. I know you're going to that dimension, because people would like to connect it with a natural tooth. Yes, the research shows that the 5-year and 10-year success rate is around 78%. It's not high, but it's still close to 80%. So the one thing you have to do if you're going to connect the implant with a natural tooth, you need to make sure natural tooth has no periodontal disease, no morbidity. Then you can connect it. I don't think we need to have the stretch breaker like we used to believe. I don't think that's the issue. As long as you can maintain it and the natural tooth is solid, then you can connect it. I did several. I don't have a problem. So I think it's possible. But if you have a space there, if patient can afford it and you can do a GBR, it's better not to connect. It would be more long-term predictable. So let's put it in that way.
And number 28 is not overly restored, and doesn't have root canal or a post, which is definitely in its favor as a possible, treatment if we couldn't place another implant 29. Alex, you want to go and show what you did on this case,
Sure.
please?
Yeah, so we can move on to the next slide. So given the, so next slide, please. So given the situation that the patient wasn't really willing to remove the crowns, so we were not able to really get a predictable bone augmentation procedure. So after we opened the flap, you could see on the right hand side and left hand side, the bone architecture was actually more flat architecture instead of well-maintained defect. So that's also another question that I want to ask Dr. Wang. I mean, how deep the defect and what's the angle of the defect that you would consider to attempt the GBR procedure? Because in GTR, we have a good amount of literature talking about potentially 37° to 45° could be a good angle to really attempt the GTR procedure. How about dental implant situation? Because in this case, the bone loss looks relatively a flat architecture. Would you still attempt GBI if in this kind of scenario?
No, actually, we published a paper with Alberto Monge this year on the defect angle to predict the regeneration outcome. And I think somewhere around 30 degree or 37 degree will be the more pliable for the GBR, but more than that is difficult. And also the other things I look at is if a patient does not want to remove the crown, anything more than 50%, I will say no chance. But if a patient willing to remove a crown or prosthesis, I will give one try. And because I can grow bone that vertically, so I give it one try, but depends on the patient.
Okay, thank you. So let's move on to the next slide, please. So this patient was actually treated with implantoplasty, as Dr. Wang, you mentioned, especially on the buccal and the distal side of number 29 implant. You could see some marking of the burrs on the 29 buccal side. And next slide, please. After the implantoplasty was performed, the tissue was actually apically positioned to really position the tissues more apically and expose the part of the polished abutment on number 29 distal and the buccal. The goal of this procedure is actually not trying to regenerate the bone for the patient. Instead, the goal of the treatment turned out to be increasing the access for the patient to clean the embryonial space between number 29 and number 30 implants. So next slide, please. So now after the 2-week follow-up, the patient came back for the post-op follow-up, and you could see quite a lot of recession on number 29 buccal and the number 29 distal implant. And the tissue was still granulating into the embryonial space. And we kept following up with this patient. Next slide, please. So the patient came back for the 2-year follow-up. So on the top side of this slide, you could see the 2-year follow-up of the radiograph and clinical photo. And the bottom part is the lingual side of the 2-year follow-up on the right side of the screen. And left side of the screen, you could see the initial radiograph before the treatment. So apparently, the aesthetic-wise, the patient got more exposure of the abutment of number 29 implant and a little bit on the mesial side of number 30 implant. But after the 2-year follow-up, the bone level was considered pretty consistent compared to the 2 years ago, which it was before treatment. Tissue tone also looks healthier compared to the pre-treatment status, and the abscess did not really come back to bother the patient again. So this treatment is actually very different from what Dr. Wang you proposed, which is totally fine. And we just want to know about your thoughts on this type of the treatment, which would be apically positioned flap plus the osseous resective implantoplasty instead of doing a regenerative procedure. And you also mentioned that titanium particles, it is a very controversial topic, and you personally do not really have the experience of the foreign body reaction. How about some more ideas in terms of the biocorrosions and potentially releasing some titanium particles? Do you think that could trigger some peri-implant bone loss as well?
I think the first of all, the case actually maintained very well. It's stabilized, so it didn't go further. That's one thing. If you create an open access for the cleaning, you certainly can achieve that. That's called stability. You can see that. And the biocorrosion, personally, I don't see it for my career yet, but in the orthopedic, yes, that they do talk about it, but I didn't see that. And the same things like titanium particle trigger, the foreign body reaction. I don't see that, not in this case also. So I think the key is to create a space for a clean. If a patient does not care about aesthetic, I still don't like the crown contour because I think it's over contour. So that's, to me, I'm more idealist. I like to see something more beautiful long term. But again, if a patient happy with this, it can get access to clean. Implantoplasty is okay. But what you need to be careful is a 2 years follow-up. You miss a distal wall, it's very thin. It's a very risky. So that's something I'm more worried, because if that's fracture, implant removal can be a little bit challenge, because you lost the one thing using the implant removal kit to remove it. But again, it looks very good, so that if a patient can maintain it. And the very good news is that you have the free gingiva graft done before, so it's stabilized. And one of the criteria I do implantoplasty or the APF to treat in my case is something like you say, if the patient does not want to remove it, or anything less than 50% of a bone loss, I can consider. Most likely 20 to 25% will be the ideal. If you only lost 20 to 25 like this case, that would be the ideal indication.
Hom-Lay, what's your experience with a case like this lasting? Because there's a number of clinicians today that would say, I see this, I take that implant out. And to me, that could be, in some patients, very aggressive. So what is your thoughts on that, Hom-Lay? Because I've seen cases with implantoplasty that's still okay after 25 years.
The study we did with Dr. Ravida, and we showed that if you lost then 25% of a bone loss, and if you have a 25 to 50% of bone loss, and more than 50% of bone loss, and you perform implantoplasty, the chance for you to keep that implant, it's 18 times more to lose when you have more than 50% of bone loss than the 20 to 25% bone loss implants. Then it's about almost 9 times more likely to lose when you have a 25 to 50% of bone loss than less than 25% of bone loss. So again, the implantoplasty is good for mild to moderate bone loss group, not the severe group.
Yes.
And longevity can be an issue for that reason.
Because the bone loss is maybe 50% or less in this case. So, to me, there's a rationale to try to save this tooth, this implant, especially based on the age of this patient and the desire not to want to remove the crowns.
Yeah. One thing I forgot to mention is that study we published that if the implant is less than 4.1 millimeter, such as 3.7, when you do implantoplasty, there's a more high risk of a fracture. So that's just some things have to think about it.
Yeah, exactly. Good point. Briar, any questions from the audience? Question from Absalam. Hi, Abdu. How are you? Why not a collagen membrane? Actually, one of your students is asking that question.
We did a comparison between the collagen membrane non-submerged group versus the submerged group with PTFE membrane, and we actually did much better result. And recent article, 2 of them published from European group, they all suggest the collagen membrane treating the periimplantitis does not give you a positive benefit. So I think when treating the periimplantitis, using collagen membrane may not be a good choice or good option, at least from the literature at this moment.
Okay, thank you.
Because it may trigger a foreign body reaction for that foreign substance, like a collagen, and that may change in the bone maturation. I don't know the true mechanism, but my suspicion is that way.
Okay, any other questions, please?
So, Dr. Wang, since you keep talking about that free gingiva graft that I did before, do you want to comment on the timing of your tissue, your phenotype modification therapy for the patients? A lot of the time, we might be able to do it before the implant placement. Some people do it at the time of the second stage approach. Some people do it after the final restoration. From your experience, would you mind talking to us what ideal timeline that you would perform your phenotype modification therapy?
I think the phenotype modification does not matter when do you do it, as long as you do it well. You do it before, during, and after, it does not make a huge difference. In a case like in this case, I think what you did is because when you have over-contour, then you need to have a thick phenotype. You do need a phenotype modification to get you a 2 millimeter thickness, so you can slow down the disease progression. And that has been documented by literature. So I would do it for sure when the restoration goes down. I would like to see it. But if you are trying to do a vertical bone augmentation, then I will postpone my soft tissue graft to the later on, because I want to release my flap to close it. If I do a free gingival graft or the soft tissue graft, I may have a scar tissue. So it's difficult for me to release the flap the way I want. So it really depends on the indications. So I don't think about timing is the issue. You can do either before, during, or after. Depends on the purpose of your treatment or surgical procedures.
Great. All right, we got time for one last question. Anybody?
So from Dr. Ko Keng Hong, so Dr. Hong asked about, so Dr. Wang, you mentioned about the perforated PTFE membrane, which is the relatively new material on the market. In the past, probably 5-10 years ago, people were still using a non-perforated dense PTFE membrane. Do you think the perforated one really have the benefit in dealing with these type of cases, or you think using non-perforated one would be okay?
I think those of you ever did a PTFE membrane non-perforated, you can see when you take the membrane out, that bone graft look like a less blood supply, more white color, and sometimes it's soft and move. So that's what Dr. Urban actually went into doing the perforated. And when I use the non-perforated membranes, I will actually drill a hole with my long burr to create a perforated PTFE membrane. So I did perforate it anyway. So I still like the blood supply. So I always suggest you have to think about blood supply. One of the major problems for PTFE is a flap sloughing. So you don't have a blood supply, you're going to slough the flap. So I prefer you do a perforated.
Good point.
And we still have the last question here about the crown removal. So Dr. Hong also asked about when the crown is removed, when would be the timing for you to wait? How long will you wait before you attempt your regenerative bone augmentation procedure? And in addition to that, after the regenerative procedure, how long would you wait to really fabricate the final crowns for the patient?
So basically, we take a crown over, put a heating cap. We let it heal about 6 weeks, soft tissue heal. Then we can go ahead and do a GBR, because that time is much easier to release and you don't have a huge hole, and you can close it with the primary closure. And when can you do the new crown? When you do a regeneration, the way I propose, I'm a Chinese, so I have to say that I like a number 8. So I usually wait for 8 months. But Urban used to wait for 9 months, but now he's trying to switch to the 6 months. I think you wait 6 to 8 months is fine, but I like to 8 months because we are using some of the xenograft or allograft. I like to see the full bone maturation. And once as a bone is healed and you do a stage 2 or a soft tissue manipulation, and you can put a crown after your soft tissue mature, usually by 4 to 6 weeks after.
Great. All right. Hom-Lay, I want to say thank you. And my co-host, Alex Lin, appreciate the case sharing. This has been terrific for our first inaugural AO Hot Seat. And let's go to our last slide. We'll introduce our second Hot Seat guest, which will be Dr. Charles Goodacre. And that'll be Wednesday, January 10th. So on a period of about every 3 months, we will have another Hot Seat. And we'll be switching through the different specialties, including general dentistry. So I want to thank everybody for attending, and thank again Dr. Hom-Lay Wang, Alex Lin, and our group behind the scenes, Joe Kahn, and also Lorenzo Tavelli, and also Briar Boy, who's also in on this. So thank you all for attending, and we'll see you next time, January 10th. Appreciate it.
Thank you, everyone.
Thank you.
Thanks.